Hi, everyone. Welcome. Thank you for having me tonight. My name is Amanda Amidasetti. I'm an M2 at Rutgers Robert Wood Johnson Medical School, and I'm very excited to talk to you tonight about extent of resection in newly diagnosed glioblastoma. So this is the paper we'll be discussing. It's a study published on February 6th of 2020. It's a retrospective multi-cohort study to assess the association of extent of resection in conjugation with molecular and clinical information to develop recommendations to guide cytoreductive surgery in newly diagnosed glioblastoma. So I just want to lay some foundation before we jump into the paper. When we discuss extent of resection, it's critical that we consider both components of tumor, both the contrast enhancing and non-contrast enhancing components. So contrast enhancement occurs in areas where the blood-brain barrier is broken down and contrast extravasates into the parenchyma. So this doesn't necessarily happen in all tumor cells, but happens in the bulk tumor, as you could see here in this axial T1. So glioblastoma is a highly infiltrative disease, so not every cell will contrast enhance. The surrounding brain tissue is actually infiltrated with glioblastoma cells that are not showing up on that MRI. And this concept is illustrated well in the schematic at the bottom of the slide. As you could see, this bulk area of the tumor will contrast enhance. And even after you resect it and apply temozolomide and radiation therapy as per the standard of care, these infiltrative cells still persist and they don't contrast enhance, so you won't necessarily see them. And they can facilitate recurrence of disease. In fact, 90% of recurrence occurs within 2 centimeters of that original tumor border, which further supports examining extent of resection and possible paradigm shift. I'll briefly go over the molecular subgroups, but Dr. Adamson actually did a good job of going over this in series 1. Or episode 1 of the series, so you can refer back to that for more information. But very briefly, IDH mutations and MGMT methylation are both positive prognosticators in glioblastoma. As you could see, the median overall survival for wild type IDH is 1.2 years, and in IDH mutants, that number goes up to 3.6 years. IDH mutants account for 9% of all glioblastomas, and they occur in a younger age. They also tend to be in tumors that arise as lower grade glioma and then progress to high grade. MGMT is a DNA repair enzyme. When it's methylated, it's not functional. So these tumors are more susceptible to alkylating damage from temozolomide, and thus this is also a positive prognosticator. So the research question this group sought to answer was, is maximal extent of resection of non-contrast enhanced and contrast enhanced tumor associated with improved survival within molecularly defined subgroups of newly diagnosed glioblastoma? These are the methods that the group used. They used a development cohort from UCSF, which contained 761 patients, as well as 2 validation cohorts to confirm the results, one from the Mayo Clinic containing 107 patients, and one from Cleveland Clinic, Ohio Brain Tumor Study, which included 99 patients. The image reviewers were blinded to the patient groupings, and outcomes reported were overall survival. This flow diagram guides you through the process by which they split patients up. So as you could see, they started with 1,321 patients, and they applied the eligibility criteria, which were patients that had surgical resection for newly diagnosed glioblastoma, available survival, molecular, and clinical data, as well as available pre-op and post-op MRIs. They were then further sorted by IDH and MGMT status, and past that, they were further sorted by the year of diagnosis. If you recall, the STOOP protocol was introduced in 2005, and that markedly improved glioblastoma survival. So this was done to avoid any confounding with that. Okay, this was their statistical approach. I included part of the table from the paper. You don't have to read every line, but this is just to illustrate that there were various characteristics between groups that were considered, including sex, age, Karnakovsky performance score, tumor location, post-op tumor volume, extent of resection, as well as post-op adjuvant therapies. An unpaired two-tailed T and chi-square tests were used to test for differences in these variables between the cohorts. And Cox proportional hazard regression models were evaluated associations of these variables with survival. However, the proportional hazard assumption was not met in all models, so recursive partitioning methods were used. And these survival trees divided patients into different survival risk groups, which I'll show you in the next slide, because this is how the outcomes were reported. Okay, this is the recursive partitioning method used, and you'll see temozolomide after surgery was the first bifurcation. So all patients were put into this model. If they were not treated with temozolomide, they were put into group 1. If they were treated, then they were further split by IDH status. IDH mutants automatically went into group 4, and then IDH wild type patients were further split by their age at the time of diagnosis. Group 2 included these IDH wild type patients who were over 65. The younger cohort under 65 was then divided once again based on the extent of their resection. So if they had a lot of tumor left, a lot of the non-contrast enhancing tumor left, you could think of this as an incomplete resection. They were put into group 3. And if they had a smaller amount of the non-contrast enhancing tumor left, you could think of this as a more complete resection. They were put into group 4. This is a busy slide, but this shows the Kaplan-Meier curves for all of the groups that we just talked about. We can focus on panel A for right now. This shows the 4 groups and their survivals. As you can see, group 1 is shown in this gray line at the bottom, and they had the poorest overall survival. Their median overall survival was 3.6 months, and this was the group that did not receive any temozolomide. Group 2, which is this orange line, consisted of older patients who were IDH wild type. They did receive temozolomide, and they had better survival than group 1 at 12.4 months. Group 3 are the younger patients. They're IDH wild type, and they had a large amount of non-contrast enhancing tumor left after surgery. So they had better survival outcomes than groups 1 or 2. Their median overall survival was 16.5 months. Finally, group 4, which is the combination of 2 groups, they had the best survival outcomes at a median overall survival of 37.3 months. Now, if you recall, this group consisted of 2 subgroups, and that's what's shown here in this split Kaplan-Meier curve. Group 4A is shown in blue, and these are patients, the younger patients with IDH wild-type tumors and complete non-contrast enhancing resection. 4B is shown in red, and these are IDH mutants. Notably, they have similar survival curves for up to the first 3 years, and then after that, the IDH wild-type declined faster. Panel C shows the validation cohorts, and it shows that the data is consistent with the development cohort. So these are the same results. I created this table just so you could see the patient characteristics within each group a little bit more clearly. As you can see at the top, I've listed the group, their age, IDH status, the extent of their resection, as well as outcomes, including median overall survival and 95% confidence interval. So you could take a look at this if the Kaplan-Meier curves were difficult to understand. And it's notable that the association between aggressive contrast enhancing and non-contrast enhancing resection in patients with IDH wild-type tumors was not attenuated by MGMT methylation. Okay, so the reduction in relative death was noted for contrast enhancing resections greater than 80%. And there was an increase in relative death rate noted for contrast enhanced resections that were less than 40%, with a plateau effect between these 2 margins. The median percentage of contrast enhanced tumor resection was 97%, and the median percentage for non-contrast enhanced tumor resection was 54%. Analysis with IDH wild-type cohort also showed that young patients with the most complete contrast-enhancing and non-contrast enhancing resections had the best survival outcomes. With regard to contrast-enhancing tumor resection, that's really where the variability is occurring. Oh, pardon me, I misspoke. With regard to contrast-enhancing tumor resection, everybody benefited from receiving that, so that was incorporated into the surgical strategy proposed. Okay, and the surgical strategy was developed based on these last 3 bullet points in bold. The reduction of contrast-enhancing tumor was significant regardless of IDH or MGMT status. Reduction of non-contrast enhancing tumor was significant in 2 subgroups. 1, in younger patients with IDH wild-type tumors, regardless of their MGMT status, and 2, in all patients with IDH mutant tumors. And finally, reduction of non-contrast enhancing tumor was not significant in patients over 65 years of age. Notably, this is the first study to show that benefit of maximal non-contrast enhancing resection outweighed the possible negative prognostic implication of IDH wild-type status in younger patients. This is important because extent of resection can now be thought of as a modifiable risk factor. You can't change the tumor genetics, but you can change the surgical management of how you treat these patients. So this is the proposed surgical strategy based on these results. Contrast-enhanced tumor resection is recommended for everybody where it can be safely done. In addition to the contrast-enhanced tumor resection, non-contrast-enhanced tumor resection is recommended in patients younger than 65. And this seems remarkably simple considering the complexity of the study. And this is because IDH mutant patients tend to be younger. The median age of onset for those tumors is 38 years. So they're actually incorporated into this younger group here. While it seems like the strategy sorts solely by age, genetic composition of the tumor is in fact taken into account. Limitations of the study were that it only considered tumors that were surgically resectable. 3 large centers were included, and while the numbers were statistically significant, this may reduce generalizability because it was only 3 centers. Not all genetic markers are actually available at the time of treatment. Many times biopsy is done at the time of tumor resection. We're not able to draw conclusions based on this paper on neurological compromise, and further investigation is warranted into discrepancies between past studies on IDH mutations. A randomized clinical trial would be ideal, but of course this is difficult in rare diseases like glioblastoma. All things considered, this is a well-designed study that effectively assessed a large cohort of glioblastoma patients for outcomes, which is difficult to do. Future directions in this body of work, once you decide to do maximal resection or resection that includes non-contrast enhancing areas, methods like fluorescein and 5-ALA can be used to highlight these areas that might not show up on MRI. 5-ALA is very specific for tumor cells, and that's the picture shown here. You can see with an operative microscope at the time of surgery, you can actually see any cells that you may have possibly left behind or any tumor particles that you may have left behind. Supratotal resection is also being investigated. There's a lot of work being done in this area, UMiami, if you're interested in more. Functional and stimulation mapping can be used to show you which parts of brain you should leave untouched. So the first 3 methods here can guide you in deciding which parts to resect, and the functional stimulation mapping can be used to reduce postoperative morbidity. Sera biomarkers are also being developed for genetic classification and can aid in this type of work where we're characterizing based on tumor genetics. These are my references and acknowledgements, and I'm happy to take any questions. Thank you so much.
Great.
Yes, so if anybody has any questions, feel free to send them in the chat. If there's anything Dr. Hadjipanayis wants to add, we'll give him time to do that.
Yeah, really nice job, Amanda. I think you did a great job providing an overview for this. You know, this paper really touches on, can you guys hear me okay, by the way? Yeah, this paper really touches on a lot of important points that have been analyzed through the years. So maximal extent of resection has always been the mainstay in glioblastoma surgery, but we never really understood, you know, how much of an impact it had and really what types of tumors did better than others. Traditionally, prognostic factors in glioblastoma have always been age, KPS, extent of resection, MGMT methylation. But, you know, recently there's been this push to understand exactly what glioblastoma subtype, age status, and IDH mutational status can benefit from maximal resection. I think this paper was able to get to some of that with its larger number of patients. And we do know that older patients with glioblastoma in general just don't do well. If you look at, you know, the older patients above 65, their survivals are usually within that median survival range you see, whereas younger patients typically have a little bit higher survival. And of course, if you add the MGMT subtype and the mutational status, that changes things as well. one of the challenges is, why can't we perform these maximal resections all the time? And that's something that, when you look at the literature, actually, if you get 50% of all GBMs getting a maximal resection, that's actually pretty good. If you look at a lot of what's been published out there, much of what we've seen in many centers is less than 50%. And that's where our jobs as neurosurgical oncologists is really to try to push that needle higher. And today's theme is going to be 5-ALA fluorescence guided surgery with extended resection. And the reason for that is because it's another tool that allows us to really push things along and see the tumor better. And I think that's what you had mentioned in future directions is how can we consistently perform maximal resections? But the other part to that is also understanding how well we could preserve neurologic function. So, going in and taking out the tumor is great, and getting a great postoperative MRI scan may make you feel better. But if your patient is paralyzed and plegic on the opposite side of the body, that is not a win situation. That is a lose situation, because that patient can't go on to other therapies. They can't get their radiation. They can't get their chemotherapy. And you really haven't done the patient any favors by that type of resection. So there's always this balance as a neurosurgeon, is how much can you take without hurting your patient? And you always have to keep that in mind. And as you get more and more skilled with your surgical resections, you'll know when to stop. And that's what you have to do. You have to know when to stop. And the other tools that you mentioned are intraoperative mapping. That's something I routinely do with all my resections. I'll do cortical, subcortical mapping, phase reversal. I want to know exactly where this tumor is in relationship to other parts of cortical spinal tracts, language pathways, et cetera. And we do tractography for all our patients. And it's just data that we can use to basically bring together so that we make the right decisions during surgery. So, these types of papers help us understand that we can make a difference as surgeons in our patients' outcomes. And one of the things, when I was training early on, the neurologist and other oncologists would say, listen, you can't really make a difference with surgery. It really doesn't make a difference. And the reality is, absolutely, it does make a difference. So don't let anyone ever talk you out of that, because you definitely can impact the survival of a patient based on the resection you perform and how you preserve their function. Do we have any questions that we could discuss with the paper? Yeah, there's another meta-analysis from 2016 that was published by Brown et al. In JAMA Oncology. And the nice part of that paper, we're not discussing that today, but that was a meta-analysis of over 41,000 patients. And they basically stratified patients who had a gross total resection or didn't. And again, they showed with pretty strong evidence that the more you resect, the better the patient outcomes. And if you achieve a gross total resection, that those patients did live longer.
Excellent. If there are no questions, I think we can move on to Sandra's presentation.
Excellent. Could you enable screen sharing for me? I got logged off earlier, and when I came back, everything was different.
Yeah, I just made you a co-host, so you should be able to share screen now.
Thank you.
Mm-hmm.
Okay, so can we see my screen?
Yep, you're good.
All right. I want to thank Dr. Hadjipanayis and the Neurosurgery Training, the Medical Student Neurosurgery Training Center for hosting our series and journal group. And my name is Sandra. I am an M2 at the University of Buffalo, and I will be discussing the use of 5-ALA, aminoluluvinic acid, for the resection of high-grade glioma. And this is the result of a clinical trial that was conducted in 2006 and published in Lancet Oncology. And this is the citation for reference. And here's a picture of myself and my family. And I have no conflicts of interest. So, as we've been discussing over the past couple of weeks, malignant high-grade gliomas are locally invasive brain tumors that have a poor prognosis for the patient. And as you can see in this table, the median survival for patients with, say, a type 4 glioblastoma is 15 months with a 27% 2-year survival. And these tumors, we have about 10,000 new cases of glioblastoma every year in the US, and worldwide 238,000 new cases of brain tumor with 174 deaths annually. So this is a condition that impacts a lot of people. And as we've been also discussing, the treatment for high-grade glioma consists of maximum cytoreduction or resection of the tumor, followed by radiation therapy and adjuvant temozolomide chemotherapy. And so prior to 2006, or around the time that the study was published, fewer than 20% of patients were able to, surgeons were able to get maximum cytoreduction of contrast-enhancing tumor in fewer than 20% of patients. And the reason that was cited is difficulty in defining the margins of the tumor. And some of the modalities that surgeons had to define the margins of tumors included intraoperative MRI, neuronavigation, ultrasound, and fluorescent dye. And the only modality that was studied was MRI, and the study found that there was no benefit as far as tumor resection when MRI was used. And there are also several problems with using these modalities intraoperatively. And so none of these methods were regarded as standard for use in malignant glioma resection at the time. And like we've also been discussing today, like, why is this even important? And this is because there's a survival benefit that's associated with complete reduction of the tumor. And this benefit was compounded as this clinical trial found that for patients who had complete resection, there was an additional benefit, or these patients received the most benefit from temozolomide regimen as compared to patients who had had incomplete resection. And for patients, disease progression marks a burdening treatment time for the patient. This means that they have to have additional chemotherapy or repeat surgery. And the paper cited that clinical experience shows that there's a correlation between radiological progression of a tumor and clinical deterioration for the patient. And this really was the basis of this study. They wanted to see, or they wanted to analyze, see if the use of 5-ALA was able to help in visualization of the tumor. And so you ask the question, what is 5-ALA? It's a natural biochemical precursor of hemoglobin that leads the synthesis and accumulation of fluorescent porphyrins in epithelial and cancerous tumor, but specifically in malignant glioma. And unlike other fluorescent agents that have to penetrate the defective blood-brain barrier, 5-ALA is not reliant on the blood-brain barrier to accumulate within the glioma. And this clinical trial wanted to assess the effect of fluorescence-guided resection with 5-ALA on surgical radicality, progression-free survival, and overall survival and morbidity. And so while this slide is a bit busy, it just shows the overall methodology of the study. So they enrolled 322 patients at 32 investigators at 17 German centers from 1999 to 2004. And the patients were followed for a median of 35 months. And Patients were identified using the criteria that they had a distinct ring-like pattern of contrast enhancement on MRI with irregular walls. And there was also a reduced signal that suggested a necrotic center in the tumor. Patients were also evaluated for exclusion criteria. And one of the exclusion criteria that I want to mention is that the tumor location did not enable complete resection. So if the tumor was located in a region where complete resection was not possible, those patients were removed from the study. And they were both randomized into two groups, one being patients who received ALA, and this was given as 20 milligrams per kilo prior to surgery, and this was oral formulation, versus the control group that use conventional microsurgery with white light and a traditional fluorescent dye like fluorescein. Patients received Decadron prior to surgery, and this was in both groups, and they had they followed a stop protocol postoperatively. And this means that the patients, both groups got radiation of maximum dose 60 guys given at 2 guy increments over 6 weeks. And however, patients who had cancers that were susceptible to chemotherapy were allowed to get chemotherapy prior. And once the tumor resurged, patients were not restricted from receiving chemotherapy. Data was collected at different time points, and the study needed in its initial design about 350 patients to achieve 80% power. And an interim analysis was scheduled at 270 patients. At 270 patients, the study did an analysis that showed that there was a statistically significant difference between the two groups, and this was achieved at 80% power, and so the trial was ended at that point. So if you look at this diagram, it shows the two arms, and it shows like the characteristics of patients in both arms, and they were randomized such that they were distributed equally by age, Kanofsky Performance Scale, which is an evaluation that can be done that indicates the prognosis of a patient that's diagnosed with a glioma. Tumor location, that is the tumor located around an eloquent or non-eloquent area in the brain, with the eloquent areas being areas that control either motor function, sensory modalities, or cognitive function in the brain. And also patients, after pathological analysis was done of the tumors, the patients were randomized such that they had fairly equal characteristics in the cancerous tumor size. The study was designed such that patients were randomized prior to the surgery. And so after the resection was completed, samples were sent to pathology, and some patients were eliminated from the study at that point. It's important to note that 261 out of the 270 patients had a grade 4 WHO grade 4 lesion, and 237 of the patients had a GBM. These are the primary endpoints of the study. So the first endpoint was what proportion of patients had histologically confirmed malignant glioma on central neuropathological review without residual contrast-enhancing tumor and post-operative MRI. And this MRI was completed within 72 hours after surgery. The second primary endpoint was progression-free survival at 6 months. Secondary endpoints included residual tumor volume on post-op MRI, overall survival, and the type and severity of neurological deficits after surgery, and also what are the toxic effects of ALA. In result, they found that more patients assigned to ALA were without residual contrast-enhancing tumor on early MRI as compared to those with white light, and this difference was 29%. On this table, you can see that 90 out of the 139 patients who were assigned in the ALA group were without residual tumor on postoperative MRI as compared to 47 out of 131 with white light. When progression-free survival at 6 months was compared, it was higher for patients with ALA as opposed to those with white light. And the difference between these groups was 19.9%. So that was very significant, very significant. As you can see in this graph here, it shows the progression-free survival for the white light group as opposed to the ALA group. And I just want to point out at the bottom of the table, it shows numbers at risk. So as the study progressed over time, you had less patients that remained in each arm of the study. But as you can see, there are more patients in the ALA group than in the white light. But the study was not powered to detect overall survival, and it was not designed to do so. But I point this out to note that progression-free survival is graphed as a percentage of the total patients. And for the patients with white light, the median progression-free survival was 3.6 months as opposed to 5.1 months in the ALA group. And so the patients with ALA, they took longer for their tumors to progress. When subgroups were analyzed, they found that this 6-month progression-free survival was found in patients that were older than 55. They had a Kanofsky performance scale that was greater than 80. And in both areas where the tumor was close to an eloquent area and where it was not. And this benefit was not found in patients 55 or younger with a Kanofsky scale between 70 and 80. So if we go back to the primary and secondary objectives of the study, when you ask the question, was there any residual tumor on postoperative MRI? For both groups, they found that residual tumor was small. And however, the median volume was significantly smaller in the ALA group as opposed to those in white light. For progression-free survival at 6 months, this again was higher. It was higher with patients with ALA as opposed to those with white light. The severity and type of neurological deficit after surgery, when post-operative Kanofsky performance score, neurological status, and toxic effects were compared, they were much the same for both groups, and this indicated that ALA was safe. This study had some limitations, and the one being that it was not powered to detect overall survival. And there was some inconsistency in intraoperative diagnostic procedures. And this means that surgeons were allowed to use any modality that they saw fit to plan the initial surgical approach, as well as localize the tumor once they began the surgery. But they were only allowed to use either ALA or standard fluorescence, white light, to localize the margins of the tumor. There was a mixture of grade 3 and grade 4 tumors, and the STAR protocol was slightly inconsistent with patients, with some patients allowed to have chemotherapy earlier than others. So it is possible that these limitations might have introduced some bias into the results, and further studies were needed to address these limitations. But in conclusion, high-grade gliomas are very invasive tumors, and they do have a poor prognosis for patient. Complete tumor resection is essential because it does provide clinical benefit for patient, and this benefit is additional. It's an additional benefit to the adjuvant radiotherapy and temozolomide regimen. And ALA did provide a clinical benefit for patients on removal of tumors. Thank you. I apologize for my kids. They were told to stay downstairs, but they didn't.
Dr. Hadjipanayis, I think you're muted.
Sorry, I said nice job, Sandra. I think you should let your kids into the room with us and join the presentation.
Yeah, they've been trying to get in here all evening.
I hear them. Yeah, that's good. I have 3 myself. It's kudos to you. It's hard. But they're great. Nice job. So I think, a couple things we need to talk about with this paper. So first of all, this is a landmark paper that to this day, we still haven't been able to reproduce in another study. So we really don't have any other randomized extent of resection study that's ever been done. If you look at some of the extent of resection papers, which you heard about one tonight by Amanda, these are all kind of papers that were done either in meta-analyses, retrospective analyses, et cetera. There's never been like a prospective study looking at that specifically for extent of resection and patients who undergo craniotomy. As you can imagine, it would be very difficult to tell a patient, okay, well, I may take out more of your tumor. I may not take out as much as your tumor. I mean, people want to have as much of their tumor resected as possible when they go through surgery. The other point here is that, this study was really ahead of its time and a very difficult study to perform, because imagine a new technology that's just being introduced to neurosurgeons and then taking a group of neurosurgeons and enrolling them into a clinical trial to understand the effect of that technology. So you can imagine the challenges associated with that, with getting the learning curve flattened in those neurosurgeons to be able to use the technology properly. In that study, I think, neurosurgeons had to perform at least 5 cases with fluorescence-guided surgery. The randomization was not a placebo-controlled randomization, so that's one critique of the study. In other words, patients before they went to surgery were either put in the white light group, where they just underwent conventional white light microsurgery. They didn't get fluorescein. I think that was something that you kept saying, Sandra. They just got standard white light from the microscope, and they went through surgery. And then the other group got 5-ALA, and then they went through fluorescence-guided surgery. But in any type of surgical study, there's always going to be bias, right? I mean, could Sandra or Amanda, can you give me your thoughts? Like what do you think would be a bias in a surgical study that's randomized? Just off the top of your head. I don't expect you to know it all, but what comes to mind?
Technique.
Okay, so technique. One of the things with this particular study is, let's say you're in the white light group, okay? And you turn on the blue light and you don't see fluorescence. Well, then you're going to know exactly what group you're in, right? So the question is, could neurosurgeons sneak and turn on the blue light and understand which group they are in, and then could they then confound the study results? So that's the type of stuff that needs to be looked at in studies, because believe it or not, there are whether you are intentionally doing it or not, those types of things could really disrupt the study. So that's one of the critiques with a surgically based study like that. Of course, if you knew that you weren't in the fluorescence guided surgery, you may leave more behind. So all this stuff kind of comes into play. The study, as Sandra pointed out, was limited though, because believe it or not, it is dated. It's 2006, but the data was collected from 1999 to 2004. Not everyone had neuronavigation used during their surgery, okay? Which becomes a problem if you're in the white light only group. Think of the cases that you've seen neurosurgeons perform surgery. We always kind of put the navigation probe in the cavity to see where we're at and just confirm that we're at that margin and we've kind of come around the tumor. Well, if you didn't have that in some of your white light cases, then the chances are you may leave more tumor behind. So that's another confounding factor. Whereas the group that got the 5-ALA, chances are they're going to see that residual tumor because it's lighting up violet red. Okay. The other thing that was disappointing with the study, and actually probably even if we went back and recreated it, probably still would not have been powered for overall survival. And the reason for that is to do an overall survival as a primary endpoint, you need to have over 1,000 patients. I mean, it's a much different study, much more expensive, much more time consuming. So that was something that just, unfortunately wasn't included, but probably because there weren't resources to do that. And, as we'll talk about just briefly with the third paper I can go over, that's what the FDA kept going back to us on. It was, well, all right, 5-ALA is a great tool. You could see tumor, but does it really make a difference? Does it really change overall survival? And we just didn't have that data for the presentation to the FDA. But we did have the data that it increases progression-free survival, as you showed, Sandra, in Walter Stumer's landmark study.
I have a question before we move on, just because you were so involved in presenting the 5-ALA data to FDA. Were there any toxic effects or adverse events reported with use of 5-ALA?
Yeah, great question, Amanda, and we didn't talk about that. So in the randomized study, and then there's been over 80,000 people dosed with 5-ALA now worldwide, and that number is continuously changing as we speak. But really the main effects of 5-ALA from the drug itself is photosensitivity. And it's only in about 10% of patients they can get a sunburn if they get out and are exposed to direct sunlight within 24 hours of being administered the 5-ALA. The real question is, if you're using 5-ALA and you're being more aggressive, are you rendering your patient more prone to neurologic deficits? So in the paper Sandra showed us now, initially at 6 weeks, when they analyzed the NIH stroke scale scores, patients in the 5-ALA arm actually did have higher NIH stroke scale scores in comparison to the conventional white light group. And that makes sense, right? If you're being more aggressive in your surgery, and we don't know if they were using mapping or if they didn't have tractography at that time. So, that's going to happen. But then when they looked at their data further out at 12 weeks, the NIH stroke scale scores balanced out and there was no significant difference between the two. So in essence, what they showed was that, they were performing more aggressive resections, and then transiently there seemed to be more deficits, but then with rehab and time, those deficits kind of balanced out between both subarms. But that's really the big question with 5-ALA, is are you going to cause more harm for greater overall extent of resection? The actual drug itself is very safe. In fact, there's been no reported deaths attributed to 5-ALA. In fact, in the FDA package, we provided them one patient in the phase 3 study was overdosed. They got double the dose of 5-ALA, and they had some respiratory depression, but then it was all transient. It got better. So that's really the main toxicity that was reported. The other stuff is just nausea, maybe some headache, and there's been some reports of blood pressure changes afterwards too. So, well, let me just briefly touch on, just to follow up with, this is the third article. One of our students had an emergency in their family. So let me just share my screen a little bit here. And I will bring this paper up here. So we had the opportunity to really work on the approval process for 5-ALA for quite a while. In fact, this paper we published last year, and it really was Walter from Europe and myself who carried the load with industry to really kind of take this to the goal line. And it was not an easy process because, most of the FDA approvals are based on outcomes such as overall survival. So if you look here at our timeline, The first dose patient with 5-ALA by Walter was in 1998. And then you just heard Sandra present the 2006 randomized phase 3 study. Europe approved it in 2007. We went to the FDA for the first time in 2011, and that was when the first IND for Glioland, which is now marketed, was opened when I was at Emory. We initiated that study. But when we went to the FDA in 2011 with the European data that led to its approval, the FDA they did not want to move it along just based on the phase 3 study. And part of that is because of the lack of overall survival data. So we had to be creative with how to get 5-ALA approved in the country, because the normal dogma was all based on patient outcomes. And the reality is that 5-ALA is not a therapeutic. 5-ALA is an intraoperative tool. That's all it is. It's a tool that we use as neurosurgeons to see the tumor. So we had to convince the FDA that it allows us to see the tumor and really not make any claims that it'll make people live longer, because that's not what we want to do. So that was really the strategy, to really take the drug and show that it was able to show malignant tumor with high diagnostic accuracy. That was what we decided to do. And we and just so you know, I want to show you guys some pictures here. Some of the concepts is that, and I do have a financial conflict, by the way, with 5-ALA. I've worked with the company, and I am conflicted, but this is just a presentation just showing you this 5-ALA fluorescence that I just want you to see. You can see it's pretty obvious here. The violent fluorescence is really amazing, and the agent is metabolized in cancer cells to its fluorescent metabolite, which is protoporphyrin IX. And that's really the difference between this and other types of fluorescence agents, is that it's metabolized in the tumor cell to show that the intracellular part of the tumor is fluorescent. This illustration, furthermore, of what we're talking about here. So we have a microscope, which is our conventional microscope, and it's been modified to emit this blue light, which is emitted at 410 nanometers, and that excites the tumor here. And that allows for the visualization of the protoporphyrin IX. So, this is the concept behind 5-ALA fluorescence-guided surgery, where you're really being guided in real time. And, the diagnostic accuracy for it is quite high, as you can see here, in the high 90s. And this is really what led it to its FDA approval. And you can see here, this is some of the data we presented to the FDA, but you can see that it is allowing us to diagnose with a positive predictive value over 95% of fluorescent tissue that is compatible with malignant tumor. And then, of course, it allows for better extent of resection and then better progression-free survival. So that led us to FDA orphan designation in 2013, and then the rest is history. But I think that was the ability to really show to the FDA that the drug is really an intraoperative tool and not a therapeutic. And I think once they understood that, and that it allowed us to resect more of the tumor, then I think it becomes an easier thing to approve. So it's kind of being used all over the place now. There's over 180 centers now that use Glioland, and it's in their formulary. And I think it's only going to go higher and higher, because it's a great tool and it's safe to our patients. And I think it's something that I believe we're going to see more and more of, even with other cancers.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.